Welcome, everyone. You're in the right place. This is Jim Gerson from CareStack. You're here for our CE course entitled Insurance Updates and Tactics for 2022, hosted by Dr. Travis Campbell. So without further ado, Dr. Campbell, if you can go ahead and move the slide one forward. We're going to talk real quickly. I'm going to make a couple introductions. Today's program would not be possible. It wouldn't be complimentary CE if it wasn't for people like Darby Dental and Jeff Daly in specific.
Okay.
And Dr. Campbell, why don't you take it away, please?
Well, thank you, Jim. Thank you both to CareStack and Darby. We used both of y'all, so we appreciate you. The one thing that always comes up, and it's been a hot topic in recent weeks, is why the hell do we deal with insurance in the first place? Insurance is evil, vindictive, whatever. But reality of the situation is, if you look at Google reviews on every office across the country, the number one complaint of any office is billing and insurance, which, okay, why do we deal with this if it's the number one cause of patients complaining, leaving, everything else? Well, what it comes down to is 80% of dental spending involves insurance in the country. And while there is always this movement to talk about going fee for service, and if you can do that, awesome, still 95% of offices in the country are in network with at least one company. So basically, majority of patients have dental insurance and we have to deal with it. Now, whether we deal with it in network, out of network, or fee for service does not matter. We still have to deal with insurance. So the big thing is dealing with it in the best way possible for us. The main thing is, and if you realize, we all know that about 50% of patients don't go to the dentist on a regular basis. Well, a majority of those patients do not have dental insurance. And a majority of the patients who do show up into the offices do have dental insurance. Whether we're contracted with them or not, our patients still want to utilize those benefits, which is why it behooves us to make sure that we can, understand the game that we're playing in the best way possible. So the big thing I always talk about is the way to understand insurance is the way to understand perception in the world to begin with. We all perceive the world in different ways depending on where we see it and our experiences. So just like this picture, you've got the same exact object, two people are looking at it and coming up with two different answers. For us, it's just the dentist and the insurance company. It's no different. We just see the same thing, the same claims, the same patient, the same treatments from two different perspectives. Well, the upside of this is if you understand it, you can realize that insurance is never going to change their ways. So if we can modify ourselves just slightly, we can make this a whole lot easier for us and get paid quicker, better, and for the patient's benefit. So the insurance game is the thing I talk about all the time because there's two ways to look at insurance. You can look at insurance as a headache and something that's going to make you depressed and beat your head against the wall. Or I prefer not to have headaches every day. You look at it as a game. I enjoy games. I have fun with games. I usually don't play games with people I absolutely hate, but every time I play a game, my goal is to win. Now, in reality, we're all playing this game if you ever deal with insurance. But a majority of times, offices don't even know what the rules are of the game, nor do they know the strategies involved. And so like any other game, if you don't know the basic rules and strategies, you will never win. The number two reason for this is, the impact to not only the office, but the patient in understanding of this game can be huge. I get dentists all the time who tell me they're having challenges with getting crowns paid or scaling root planing paid, or a variety of other things. And in most cases, it's not what they submitted or what they did, it's the documentation that they provided. So just a small change in our side can make a huge impact, not only financially for the office, but also from a stress level for everyone involved. So, a good example came up actually this week is something not to do. And this one was actually so fun, I had to post it. But someone asked the question that they saw a patient for hygiene, Delta paid primary $184, and GEHA came back and paid secondary $240. Obviously, this is higher than their normal fees. And months later, they get a letter from Delta asking for their money back, the primary insurance. The challenge is they were like, how the hell did Delta even know? Well, their office manager, who happened to also be their wife, told them, well, the patient had a huge credit, so I called Delta to find out what we should do with this credit. This one's a fun little facepalm of never, never, never call the insurance company to find out questions like this. It's a bad idea.
Great advice.
Now, for one on this is Delta's not beholden to any of this money. If you ever refund money to insurance, and in this case, money should be refunded to insurance, it does not belong to primary, it belongs to secondary. Primary will always and forever treat themselves and how they pay, irregardless of any other insurance, which means Delta does not get this 184 back. However, because the office called, they're going to end up with weeks and hours of trying to fight this because they've now started a cascade confusion effect for both the office and the insurance company. They'll probably end up not ending up having to refund the money back, but they're going to lose a bunch of money in having to fight it just in terms of paying their team to deal with it. So never call the insurance company with a question about this, please. Okay.
So, hey, Dr. Campbell, sorry to interrupt. I just wanted to share our poll results so you have an idea of your audience here. And thank you, everyone. Again, this is anonymous. But Dr. Campbell, hygienists are the highest percentage of attendees today at 35%, followed neck and neck by insurance coordinators and dentists, just to give you an idea. So
I love my hygienist. So yeah. Thank you. And you will actually love this next one. So this question comes up all the time of why is preventive treatment often not covered? We see it with adult fluoride, adult sealants, lots of other things. And the question always comes in is, dentistry is a very preventive field. So why is our main thing not covered by insurance? Well, you have to understand the insurance companies. The way they see preventive care is they're a big math company. They track everything, which means they know on average, a patient is going to stay with an insurance company for 12 months. And then whether due to job change, employer change, or the employer changing policies, that patient next year will be with a different insurance company. And so the insurance companies see preventive care as basically costs incurred now that realize benefits in the next several years. So they don't want to pay for coverage of something the next insurance company, i.e. their competitor, is going to gain a benefit from. Now, they understand that this is an important thing for the patient, and therefore they are saying by not covering it, patient, we're saying this is important stuff to do, but you are the one who's going to reap the benefits. Therefore, you are the one who needs to be paying for the service. And that's the way to kind of mold this for patients when they ask, well, is this important because insurance is not covering it? Yes, it's important, but the insurance company sees you as reaping the benefits the next few years, not them. Therefore, they don't want to cover it. It's still super important to do. Now, the next one that comes up all the time is why maximums don't increase. Now, of course, this is frustration for a lot of us because back in 1950-ish time period when insurance first came out, the annual maximum benefit was $1,000. Now, 2020, 2021, it's about $1,250. If you take that same $1,000 from 1950 and apply it to today, you're going to get somewhere, depending on what calculation you run, of $11,000 to $16,000 due to inflation. So yes, the annual maximum has gone down a lot, and premiums keep going up pretty much average with inflation. The reason for this and why this is so important to understand is it's our fault. We are the ones that are responsible for this maximum not going up. Now, I'll give you the exact scenario that happens all the time. A patient has $1,000 in coverage. They've used $950 of it. It is December, and they need one more anything, let's say a filling. They're only going to pay $50 where they usually would pay, say, $100 or $150. And so the office just tells the patient, hey, in order to do the best thing we can for you, let's put that off till January and not utilize your maximum. The insurance companies track all this data. They know that 4% and only 4% of patients across the country ever reach their maximum. And it's because offices will often put off treatment till the next year before people reach their maximum. So don't be the problem. If you want to solve this, offices across the country need to be utilizing the entire maximum before you stop doing work. So just think about that the next time the end of the year rolls around. And then the probably most frustrating one, it doesn't happen often, but thankfully, but does happen, and it causes a ton of stress, is when we, the office, call an insurance company and get one answer to a question, and the patient turns around and calls the insurance company and gets a completely different answer. To understand this one, you've got to understand corporate setup or hierarchy in the first place. When a patient calls, they are calling the patient relations or customer service department. When we call, we're going to call the claims department or provider relations. These are not the same departments. They don't talk to each other. They are not the same people. And after COVID, often they're not even in the same state. So they have no clue of what each other is talking about, and they don't even go by the same playbook. And this is where the challenge comes in. So the answer to this is, if you ever end up in this dilemma, is either get the patient in the office or at least conference call on the phone and call the claims department yourself and get the claims department to tell the patient directly what they are telling you. That's the solution to this, because they will not talk to each other. Now, let's talk about probably one of the most egregious things that's out there. The ADA disagrees with this for right, is the difference between denied and disallowed. Now, a lot of people know what denied is. It basically means we, the insurance company, won't pay, but you can charge the patient. The problem is disallows mean we, the insurance company, won't pay, and neither should the patient, which means basically you do a service for free. ADA condemns this. It's a violation of every state board's regulations, because basically insurance is dictating treatment through financing or money. It's no different than the government. The quickest way to remove a law from the books is not to actually get it off the books, it's to stop enforcing it, stop putting money towards enforcement. Insurance companies trying to do the same thing. Now, it's a violation of state boards because in order for you to disagree with my treatment plan, you have to come up with your own. In order for you to come up with your own in every state, you, the dentist, must have your hands in the patient's mouth and do a clinical exam. Well, obviously, since the insurance company can't do this, it would be a violation of any dentist, regardless of where they are, to be dictating treatment and saying that something should not be paid. So don't allow it. Now, some common disallowals, just to give you examples: indirect pulp caps under fillings, gingivectomies to access decay. Oh, the fun one, the insurance companies that will not allow you to do 4 quadrants of SRP in the same day, prophy on the same day as an SRP on a different quadrant. There's all sorts of things that happen. These are all things that are basically illegal for insurance companies to do. Now, how much are you going to fight them on it? That's a whole different story. Are there ways around it? Absolutely, but that's a much bigger topic for a different day. But just realize these aren't legal for them to do. Now, what this gets into is coding. Now, realize the one thing about coding is it is your communication with the insurance company, which means you should only ever code what you do, because it is your communication with them. Coding differently than what you do or coding something you didn't do is lying. And in terms of healthcare, this is called fraud. It's the only thing that's called fraud. Now, the thing to know is there are a ton of ADA codes that are reimbursable, and there's a lot of them that are rarely used by offices. The comprehensive exam codes are a good example. DO510 is a comprehensive exam on a regular patient. Pretty much every general dentist across the country uses this code. The DO180 is a comprehensive exam on a perio patient. Every GP should be using this code too, because all it means is that now you had to discuss perio with that patient. Well, here's the upside. There's a higher fee to this. So if you just change the code, you make more money doing the exact same thing you're already doing. So learn the codes. Now, the big blind spot that comes in here, and I hear this one all the time, is to realize that ADA codes are purely for insurance reimbursement. ADA codes did not exist before insurance existed. We were billing patients on our own, however we wanted before this. Codes are purely to communicate with an insurance company. And what this means is, if you're not expecting or going to get money from the insurance company, you don't have to use an ADA code. This is where internal coding comes in. So great examples are ultrasonic toothbrushes, prescription toothpaste. Products that you provide in the office don't have an ADA code. Make up your own. But at the same time, you can also do upgrades. So if you are going to, example, have a patient that needs a case rushed for them, there is no rush code, and insurance will never pay it. But the patient wants it and you want to provide it. Great. Charge the patient a rush code directly, do not bill insurance, and you're good to go. But that's a non-ADA code, also called an internal code. So make sure you can create these, and every software will let you. And it can make a big difference for you, the office, and you can provide some benefits to the patients. Now, the thing to realize when you talk about coding is the treatment or method of treatment is the problem. Insurance does not pay for different methods of treatment. They only pay for the treatment itself. So for example, if you're doing periodontal therapies, whether you do it traditionally or with the laser, it's the same code. Which means if you want to use a laser and want to charge more for it, you need an internal code as an additional code to the treatment that you're providing, which is the same as orthodontics. If you do metal braces versus porcelain brackets or aligners or anything else, it's still the same ortho code. But if you're going to have an additional fee or cost to the office or patient, that's an internal code. So porcelain brackets, most orthodontists charge more for that. They have a separate code for it, or they should. That's the best way to do it. You should never change the fee of a specific code you're using. If you're trying to charge more, you use a separate code. Now, some common coding concerns. I talk about this one all the time because they come up all the time. The most common complaint with coding is full mouth debridements and exams. Now, the issue is insurance will not pay for a comprehensive exam on the same day as an FMD. They just won't do it. The reason is the code itself from the FMD says you cannot do a comprehensive exam. Therefore, these codes are actually mutually exclusive based on their definition alone. This has nothing to do with the insurance company, it's the coding itself. Now, the solution to this is really simple. If you need to do an FMD on a patient, do a limited exam that day. You can bill both of these because it's not a comprehensive exam. And then what you're going to do is when you see the patient back 4 to 6 weeks later, you're going to do the comp exam at that visit. This is the way to handle FMDs. Now, palliative care is another one. A lot of people use palliative care to relieve minor pain. There sometimes is no frequency to this, but a lot of misunderstanding comes with this code. Palliative care is the treatment of the day, so you cannot send it with another treatment code of any kind, a filling, a crown, an extraction. It can't be done. They're basically mutually exclusive. However, another big concern on this is it doesn't include the examiner x-rays. These can be coded on the same day, where unfortunately, a lot of people use the palliative code as the exam. No, you can actually charge for the exam and x-rays and the palliative code all at the same time. So again, the same thing you're doing will make you more money just by understanding the coding. Now, this is 2022, January, so there are a bunch of new codes. I am not going to go through these, but now is a great time to find the print screen button on your computer. And if you don't already have these, just copy them and then go put them in your computer later. So I'll give you another second to find that print screen button before we move on. Now,
and Dr. Campbell, we did have sorry to interrupt. Everyone in attendance, this is a live program, so it's being delivered live. I know there are questions about, can you get a recorded copy, but we're delivering it to you live today. So thankfully you're here and you're taking advantage of the course today. Just wanted to make sure I mentioned that. Sorry about that.
Yep, no recording for this course. Get it now or get it never. Now, here's the important part. The codes highlighted in red Most insurance companies are saying not only will they never pay for, but if you're a network, they will also disallow. So be very careful with some of these new codes, as they're not going to be a whole lot of use of them for an in-network office. Okay, now the other 2022 insurance reimbursement change is panoramic x-rays. For the past, a lot of times insurance companies would actually restrict panos for patients ages 6 and older. However, a lot of carriers are actually removing this limitation, especially because panos nowadays have the ability to do pano bite wings on patients who are too young to do actual bite wings. And this is one way to do the panoramic x-ray. Or if you have any other legitimate reason for taking a pano on somebody under 6, often insurance will now cover it. So just a fun little thing to know about insurance trends. Now, one thing I talk about all the time, because it is one of the most commonly denied services, is crowns and buildups. Now, here's the fun part. In the past, because I hear it all the time, you could submit what is on the screen and get paid for a crown. A couple of x-rays, a very short note of why you were doing it. An insurance company would pay this 30 years ago. The problem is life changes. There's been a lot of fraud from dentists. There's been a lot of changes with insurance companies. If you send this claim, I can almost guarantee you at this point, you're going to get denied. And probably for good reason. Because if you look at these x-rays, there's not a lot to say that this patient needed work. Oh, and by the way, this is a patient of mine from this week. So just to let you know how updated this stuff is. Now, a lot of people will actually say, well, we have an intraoral camera. Let's take a picture. And this is the one I get submitted to me, or cases very similar to this, of this claim got denied. What the heck? Now, dentists, probably most hygienists, I mean, almost anybody can look at this tooth on the photo and go, yeah, that needs a crown. But here's the thing, the documentation still will not work. The way to get this covered is to realize documentation has to be a whole lot better than what's in this picture. Now, if you get even smarter and realize insurance companies often ask for the photo of the buildup, actually they usually ask for the x-ray, but they will absolutely take a photo, then this photo actually works really well to help. However, this claim will probably still get denied. The challenge is we have to provide the insurance company with better information. Now, if you get better than this, you're going to say, let's take a PA at the time the restoration was removed, and we actually determined this tooth truly needed a crown. Now, that may sound like a weird scenario, but here's what can happen. And it's happened to me, maybe 2 or 3 times in my career of over 10 years, but it does happen occasionally. We treatment plan the patient for a crown. They've got a large amalgam. They've got some small broken tooth structure. Remove the amalgam. Okay, there's no actual fractures inside the tooth, and the tooth actually looks better than I expected. So we don't actually do a crown. So the true time at which this tooth is treatment planned for a crown, 100%, is once the old restoration decay is removed. That is your pre-op point. That is the point you need to take your x-rays and photos. Now, in specific with this PA, which I've seen a lot too, this is not a good PA. I think we can all understand that. Now, my assistant was smart and immediately took a new one, but realize you can't send lousy PAs. If you're going to submit something to the insurance company, submit something that's actually easily visible. Now, so you've got a good PA. Now here is actually the good photos to send. Mid-op, you've removed the restoration, you've removed some of the decay, but left it alone. And if you have internal fractures, you can see them. You send this information, well, you might get paid. Here's the challenge. This is great visual documentation, but it's information overload. For one, you send an x-ray that was a lousy x-ray. But here's the important thing to realize with insurance companies. They're run by reviewers. The reviewers are often paid one of 2 ways. This is important information to know. A dentist reviewer is paid either hourly, and if they're paid hourly, they have a quota of claims they have to deal with. So they only have so much time to deal with each claim. Or They're paid per claim. It's typically about $1 a claim, which means if you even want to make $60 an hour as a dentist, which is pretty low, then you're going to be processing 1 claim per minute. Well, if you realize what this comes down to is if you send a whole host of information to the insurance company, the dentist is not going to take the time and energy to go through all of that. They don't have the ability to do it, or they'll lose their job, or they just won't make anything. So you have to be cognizant of what they're dealing with. If you send a ton of information that's going to take more than 30 seconds to review, and the other 30 seconds to actually, type up what they need to do as a response, your claim is likely to either get denied or be sent back for more information, because they're not even going to make it through all your details. So the thing is to realize there is an information overload problem. You don't want to send everything. So therefore, if you have lousy x-rays, don't send them. If you have pre-op photos that aren't as good as mid-op photos, don't send them. And if you have pre-op x-rays that, like these, don't really show a whole lot of problems on the x-rays, don't send them. So you want to know what a real claim looks like? That is a real clean claim. This is something that a reviewer can easily review in a few seconds and get approval. Now here's the thing, why you want the reviewers to be happy with you? They're the ones who tell you yes or no, you're going to get paid. So if you make the reviewers happy, you make their job happy, you make your job happy because you stop getting denied. This claim will get paid instantly by whatever reviewer picks it up. It's simple. The x-ray needs to show the actual problem, which means if you have a fractured tooth, remove the decay, the restoration, and the fractures, and ideally even the unsupported enamel, and that is your pre-op point. That's the point you determine absolutely, yes, this tooth needs a crown. If you're going to show a pre-op photo, show the decay. Realize a lot of the first-line reviewers are not dentists. They don't look at teeth all day long. You send them an ugly tooth like the bottom left photo, they're not going to want to look at it. They'll go, oh, yeah, obviously that needs work. Approved, move on. If you have internal fractures, absolutely show them and get a good camera to do this. And if you have a photo, or if you do a buildup, always send a post-op of the buildup. Now, that can be a photo, that can be an x-ray. Personally, I think photos are easier to take, so take a photo. By the way, none of this has to be expensive. All these photos were taken with mouthwash, which is probably one of the cheapest good cameras on the market at like $300 a piece. So this doesn't have to be hard. And it makes me sad because I used to spend like $4,000 and $5,000 per camera. It makes me sick. But now I can equip an entire office for the cost of one. Now, when you're talking about narratives, don't write out a narrative yourself. Here's the narrative sheet we use. Now, this may actually look complicated, but here's the upside of this. This is a single sheet. It's printed off every time. It literally takes about 10, 15 seconds to fill out. If you want this sheet, you can find it on my website. I'll give it to you later. But here's the thing. If you're talking about what the prior restoration is, don't say it's an amalgam. Say it's a broken tooth. That's the reason you're doing the crown. The prior restoration basically means what's the problem that you're trying to fix. Prior crowns, if you have them, you got to put a placement date on there because there's a frequency issue. Now realize the good reason of asking for frequency from the patient is to know if this crown, if you're replacing crown, is less than 5 years old and the policy has a 5-year limitation, they're not going to pay for it. So the patient needs to be out of pocket and you need to know that ahead of time. But there's a section on here for root canals, for decay, for fractures. Basically, you can get all the details you want in here. The insufficient tooth structure section is what determines that you need a buildup. Here's the thing. If you put 40, 50, or 60% on this, you will not usually get coverage for a buildup. Typically, most insurance companies want to see 65% or more tooth structure loss to justify the buildup code. So just keep that in mind. And at the end, you're telling them what information is coming with this claim. Therefore, that's what they need to look at. And then you're going to sign at the bottom that says everything you put in here is accurate. You send this off, like I have been doing for years, you will get paid a whole lot quicker. This page is a very simple, greatly documented, non-overloaded way to get your crowns paid. And it does not take long. The question I get all the time too is, oh my gosh, this is like an extra bunch of work, chair side, I don't have time to do it. Well, here's the thing. It will take you probably 30 extra seconds to take it chairside once you get used to doing it. And you will save your front desk probably hours worth of work in order to just get the thing done right. Plus, you get paid instantly as opposed to waiting 2, 3, 4, 5 months. So just keep that in mind. Now, some fun dental insurance myths that are out there all the time. I hear these. None of these are accurate. A denial means the patient did not need treatment. BS, the insurance company can't determine that. The insurance company is allowed to tell you to do free work. Nope, disallows are against state law, like we talked about. EOBs are always right. Now, there's a reason for this to be wrong, but EOBs are often actually wrong. Insurance companies always follow what they should be doing. Not really. They can get away with a whole bunch because nobody fights back on it, which is why I exist. Insurance companies or insurance representatives always have the right answers. Here's the fun one. Insurance company representatives are trained just like any other corporate person. They're trained on a list of rules that they have. If what you ask them does not fall within their standard set of rules, they're not going to know the answer. But because they're humans and they want to be helpful, because most of them do, this is not their fault, they just want to help you, they're going to give you an answer they think is right. I guarantee you, if they're guessing, they're probably going to be wrong, because most people don't understand most of the laws that surround insurance. You can offer upgraded services to patients in network. You are not required to file all claims to insurance, and patients can choose to not use their insurance. There's specifics for all of these, but I just want to have those out there as none of these myths are true. So realize that. And a lot of the courses I do throughout the year kind of answer a majority of these myths. Now, here's the thing. Why do myths exist? Well, a lot of times it's lack of interest. We are dental providers. We are not lawyers. Therefore, we are not interested in the law. We are interested in dentistry. And so because of that lack of interest, it's a lack of education and knowledge. So we go by, what's the next thing? Well, it's a perpetuated problem. If we were trained by someone who didn't know the rules, we're going to be trained incorrectly. Not because of that person's necessarily any ill intention. They were training you the exact same way they were probably trained. And the problem that comes in with that is if you were trained by somebody who was very good 20 years ago, laws change, policies change, habits change, code changes. And this change happens every year. So if you're trained by someone who was trained years ago, more than likely they're wrong on something just because they probably haven't kept up with the change. Now, why this is all important is at the Dental Insurance Guy, our goal is to be the best source of information for dental insurance possible. We keep up with these changes. We only use source material documents and we never use anecdotes. So we're not going to perpetuate rules and myths that aren't actually true. And we're going to keep up with everything. So if you've got questions, now's the time. My book is out there. It answers a bunch of this. It's actually a textbook. It's like 300 pages. But if you want the Crown narrative form that I talked about, it's free. Practice Whisper. You can go click on it and download it. There's also the decline use of insurance form. This is great for if you're doing any kind of larger cases like cosmetics, all-on-4s, things like that. Get you out of the coding for insurance. And there's some CE courses on there as well if you want to partake. So, Jim, that's what I've got as specifics. What questions do we
Campbell,
have?
thank you for such a comprehensive and efficient program. We've got a bunch of questions here, and I would encourage people to. We intentionally built in time for Q&A based on having Dr. Campbell here last March and how many unanswered questions we had. Right, so I'll try to go in chronological order. Can you please explain how to use code D4346?
Code D4346, a gingival cleaning. Best way to use this code is don't use it. Now, here's what I mean by that. The code was created for very good purposes by the ADA. There is a kind of, difference between a patient who's true perio and a patient who is healthy. There is a need for a code in between. The challenge is what a lot of people don't remember or realize is that there was a sister code to this about 14 years ago that was killed by the insurance companies. They don't like the code because there's not a lot of ways for them to verify who's different between Prophy and a D4346. So I fully expect this code within the next few years to disappear again, just like its same sister code did a decade ago. The problem with the code is most insurance companies are going to pay it very similar to a Prophy, or they're going to put it under basic, which means now you got to deal with deductibles and copays and everything else. Well, now you got to deal with explain to the patient all of this. One problem I see a lot with this code is people use it because they can't get paid on SRPs. Well, if you can't get paid on SRPs, then you need to learn how to get paid on SRPs, not change your codes. The other thing is if, insurance is just not going to pay this any different, why would you bother using a different code? You can put everything you want in your clinical notes and not have to use a different code, because the coding changes is not what's going to be a liability issue. It's going to be what you write in your notes. So just as a thing to think of, we actually rarely use this code. So there's your answer.
Okay, they're coming fast and furious. Here's one from a de novo or startup, and they're asking, they came from a DSO, associate dentists, and want to know, established in their practice, like they use the expression 10 commandments. I don't think that's really fair. How about your 1 or 2 commandments? If you were to etch your stone, Dr. Campbell, what would you recommend that they really kind of get in place to run a viable insurance practice?
Get the textbook, but no. The probably 2 biggest things I talk about all the time, and they're easy mantras to keep in place. And I'm going to make this slightly crass so people actually remember them. For one is money in hand before ass in chair. And yes, everybody needs to learn this one. But here's what it means. Do not work on a patient until they've paid you, or until you've got signed financial payment arrangements, is the biggest reason that people lose money. Money in hand first before you start working on them. And dentists are usually the problem here, not the office team. The dentist, we want to help patients. We want to get in there and we go, hey, I can re-cement that crown, no big deal. And then they go up front and they're like, oh, I didn't realize there was a cost for this. Well, yeah, because you didn't deal with it up front. Always deal with finances first. The other one is when you're estimating. Always estimate something that you are 100% sure you can get covered. If you aren't 100% certain, and this is what I tell my front team, if you aren't 100% certain that insurance is going to cover something, lower how much you think they're going to cover until you are. Which means if you're doing a filling that's $100 and you're not sure insurance is going to pay 80%, keep going down until you are sure they're going to pay that much. I don't care if it's 60, 50, 40, or 0. If you aren't certain, don't estimate. Because here's the thing. Gaining money back from a patient after you do treatment is really difficult. Giving patients back money because you overcharged them or you underestimated or whatever is really simple, and it makes people happy. And here's the thing, you don't even have to take the blame for it. Here's the wording. The insurance company told us they would pay less than they actually paid. That's awesome for you. What would you like to do with that credit? You didn't take any blame for this. And by the way, stop giving people estimates and say, we estimate insurance will pay X, Y, and Z. No, based on what insurance told us, they are going to be paying X, which means if they don't pay X, it's not your estimate that's at fault. It's the insurance company's information they gave you that's at fault.
That's a great kernel. And Dan, when we do our demos, we got to start using that from now on. I love that.
Yes, that is a good pearl of wisdom there. Thank you.
All right. So it's kind of like rapid fire, Dr. Campbell.
Keep it going.
If it's not legal, from Jacob out there, if it's not legal for insurance as the disallowed treatment that was given, then how do you get around this?
That is a much bigger topic. How you get around it is either upgrade codes, using the HIPAA forms, basically not involving insurance in the first place. The HIPAA form is the easiest one of this. It's a federal law, basically says that the insurance company is not going to get involved at all because the patient wants the service that the insurance company is telling the patient they cannot have. So for instance, a good example is a rush fee. If I'm going to do a crown, the patient's going to go out of town, say in 2 weeks, and our usual time period is a week or 3 weeks, and the patient wants it back sooner. Well, the lab is going to charge me a rush fee. Therefore, I'm going to charge the patient a rush fee. If I submit a rush fee to insurance, they will probably disallow that rush fee. So I say, screw insurance. I'm not even involving you. You need to get the patient to sign a waiver that says, I understand this added service is not covered by insurance, and I release you from your contractual obligations. Therefore, the patient can get what they want, and you can get what you want. Like I said, there is a course on that website if you want that'll go through all the details and give you the exact language of that waiver as well if you want.
Thank you. From Leon, can you add a non-ADA code for HMO? And then he has in parentheses, they don't pay you for treatment.
So simple answer is yes. Many HMOs work completely different than PPOs. So PPOs often have the idea that there's a lot of things that are included within a service. For instance, the lab fee, or at least the basic lab fee, is usually considered included within the service. Basic lab fee being the service to do the crown, for instance. Now, why I say basic is a rush fee is not basic. A rush fee is an additional fee that can be charged to the patient. Now, for HMOs, that basic lab fee often is not considered part of the crown. Therefore, yes, you can charge for the lab fee, and that is a internal code, something that you usually just wouldn't submit to insurance in the first place, because if it's not an ADA code, they're not going to recognize it. So why bother even sending it? Oh, by the way, that waiver is also in that textbook if you want.
Excellent. Thank you for mentioning the resources. Well, from Cheryl, when charting missing teeth on the ADA insurance form, are implants recorded as missing teeth?
Implant, no. If there is an implant in there, I would not chart that as a missing tooth. Does it really matter either way? No, not typically. But typically a tooth nowadays, from most of the descriptions of ADA codes, is natural or implant. It just means there's something functional there that's permanent. Actually, I think that even means a pontic on a bridge could be considered a tooth that's there. A partial is not typically, because the partial is removable.
Okay. Do you, from Annette out there, the grammar is throwing me for a loop here. Will you use code D0180 instead of D0150? Who, for a patient that presents with perio, or use instead a periodic exam code for existing perio patients? Thank you. I don't know if I butchered that.
No, you're fine. This question comes up a lot. 0180, 0150, 0120, which code to use? Here's the misconception a lot of people have. 0150 and 0180 are comprehensive exams. They are not new patient exams. Get that through your head. They are not new patient exams. They are new or existing patients. But important thing on there is they are comprehensive exams. And now, most people are going to define comprehensive as slightly differently, but here's my interpretation of pretty much every state rule on this. A comprehensive exam is one you literally do almost everything. You're going to do oral cancer screening, TMJ assessment, you're going to do a perio chart, you're going to go through their medical history. Basically, you're doing everything you would do on a new patient. Now, I don't know about you, I do this for every patient every year. So we actually do a comprehensive exam every year. Now, obviously, some insurance companies aren't going to not pay the comprehensive exam, and therefore you can get often downgraded benefits or alternative benefits. But it's a much bigger topic. But yes, you can charge an 0180 or an 0150 on an existing patient. So anyway.
So we kind of have a tied-in question there, Dr. Campbell, from Melanie. Is there a limitation frequency for 0180?
So almost every exam is going to follow the same limitations, even limited exams. Typically, it's twice a year. So many insurance companies actually won't even care which exam you use. They just do twice a year. So if you're doing 2 periodic exams a year, or one comprehensive and one periodic, you're actually going to get paid more doing the comprehensive and periodic. So just something to think about.
And then Melanie, I'm giving you the bonus question here. Because I guess I'm in a good mood. What is the conversation you have with a patient about drilling into a tooth before knowing what insurance will pay out?
For drilling into a tooth before knowing what insurance will pay out, I'm not entirely sure what you mean by that. Because we always estimate insurance ahead of time. So we're going to get a breakdown. We're going to know pretty much what insurance is going to pay. If you don't know at all, like the patient just gave you their insurance information, you can't call them, then, I mean, you know what company it is. So if you're in network, you know what fee structure you go by. At that point, if they want the service that day, have them pay completely out of pocket and then file it. I mean, because you have zero way of not only verifying coverage, but getting a breakdown. I guess that, I mean, that's what I have to assume the question's about. If it's not, you know, shoot another question.
Or reach out to Travis through his website. I want to mention that if you have questions, please put them in the Q&A. We're not monitoring the chat. That looks like there's a lot of back and forth there. Okay, so this is from an anonymous attendee. Delta pays crowns on seat date. If patient changes job insurance before seated, is there a way to get an allowance for billing by prep date by report? Note, a report was sent asking for review and still getting insurance canceled prior to treatment date. Also, patient's insurance is BC, I guess Blue Cross, and is billed by prep date.
So you can bill prep date or seat date regardless of the insurance company. Realize the insurance company paying on prep date or seat date is just saying when they will reimburse it. Now, I think what the question comes up, because it comes up a lot, is if the patient has one insurance in 2021 and one insurance in 2022, and the 2021 insurance pays on seat date, and the 2022 insurance pays on prep date, you may end up with a scenario where neither insurance will pay, just because you have that lousy situation. And you got to go to the patient and go, look, your employer, which is probably where you got the insurance, screwed you right now because of this. Now, here's the reality of it. If you have a patient that is not paying on prep date, you might not want to start that crown in December, because you're going to end up with issues. What'll often happen is down the road, and you can technically kind of push this and get payment. What'll happen is you'll get audited later. And I've been audited lots of times now. Usually they don't win. I get the audits all the time of, you know, you filed a crown in December. When did you actually seat it? Well, because the way we file it, we always submit the seat date. But you're going to get into trouble if you try to manipulate that too much. So I wouldn't suggest doing it. If you're going to get paid on prep date, great, do it in December. If you're going to get paid on seat date, wait till January before you even start. And that's the easiest way. We are busy enough in December that we don't have to front load treatment into December. Just do it in January.
Thank you for speaking to that. George, you just put out there, let's talk about the missing tooth clause. I don't know if that's a question or a statement.
So missing tooth clause. Missing tooth clause basically says if the patient was missing the tooth prior to the insurance company being enacted, basically didn't do the extraction under this policy, they will not pay for any replacement of that tooth. And that means they won't pay for a partial, a bridge, or an implant. Now, the way to get paid for a partial with the missing tooth clause is you have to extract another tooth in the same arch under that policy, and then you can get covered. Another way to do, if you want a bridge, the way to get a bridge paid, at least partially, is each abutment tooth needs to have a crown on its own. So you've got to evaluate the teeth on, do they need crowns anyway? If they do, you can get paid on the 2 crowns. You can file the bridge, but you can get paid at least for the amount of 2 crowns as a downgraded benefit. If you do an implant on a patient with missing tooth clause, you won't get paid for anything. So there you go.
Thank you for speaking to that. All right. So if, for example, an alveoloplasty is not allowed during full mouth extractions and immediate dentures, how can I get paid for this service?
Sign the waiver for the upgraded service. And I mean, it's really easy for the patient. Look, after we take out a bunch of teeth, you're going to have a bunch of sharp bone. If we leave that sharp bone alone underneath your denture, it's always going to be a sore spot. And insurance, for whatever reason, is dumb enough telling us that you shouldn't have this service, which is a bunch of BS. Sign this little waiver form for us, and then we can make this to where the denture is going to be a whole lot more comfortable for you later. I mean, kind of something like that.
Okay, so last couple questions, Dr. Campbell. I see Guardian and Cigna denying SRP a lot. What are methods to overcome this?
So that's one I'd give as a CE course a lot. It does take some time to go through. The quickest answer on that is have great documentation. And when I mean great, most hygienists and dentists that actually think they're providing good documentation for SRPs provide lousy documentation. So if you think about a perio chart is not pocket depths. It's gingival margins, clinical attachment loss, bleeding on probing. It's everything. Everything is required to get paid on SRP. The other thing to think about is great documentation in your clinical notes, because a lot of times they're going to ask for that. So I get this question pretty much every day. I get somebody send me a claim and say, hey, we got denied for SRP. Can you help us with this case? In most cases, I have to tell them, unfortunately, they're not getting paid for this one, but they can get paid for every one subsequent, because they just need to get better documentation at the time that you do it. So a complete perio chart, photos of probes and the gums, and an amazing clinical narrative will help a ton. We do about 300 SRP patients a year. We get denied like 1 or 2 of them, and every one of those we get denied, we were kind of expecting, because they were on the borderline and they were usually teenagers to begin with, and the parents are already aware they're probably going to be out of pocket completely for that service anyway. So we always get paid. It's just whether insurance is going to reimburse. So
excellent. Thank you for speaking to that. And last but not least, the last question we're going to take today is from Hillary. And then if you want to, Travis, if you want people to dialogue with you, what's the best way? I know you have your website. Do you
go to the website? There's a button on there to click that says Contact Travis.
Okay.
There's a huge training platform coming next month. If people are interested in that, go to the articles page, subscribe for the articles. You'll get a message when that platform releases.
Awesome. Thank you for speaking to that. So the winner is Hillary. How do you recommend billing laser therapy for perio?
So again, like I said, they're not going to pay for an upgraded method. They're only going to pay for the service. So it depends on the service you're doing. So let's say you're doing laser SRP. Well, you're going to bill for the SRP just like you normally would. The laser component is an internal code that you bill straight to the patient. Insurance will never pay it. They will often try to disallow it, which means ideally you get a waiver from the patient to do the laser therapy. And if the patient doesn't want to do the waiver, that's fine. Do the treatment without the laser and without that additional cost. But it's the patient's right to choose what service they want, which means the insurance company can't legally get involved. The challenge we have is we don't often get the right documentation to be able to do this. If you get the right waivers, which basically is a statement from the patient acknowledging the fact that this is something insurance won't cover, then you're good. And insurance can never come back and say anything, and the patient can't come back and say anything either. It becomes a legal document. So there you go.
Yeah, thank you for closing the loop on that. Appreciate it. Okay, so I want to. There's one question about your website. It's right there, practicewhisperer.com. It's Whisperer or Whisper?
Whisper. The Whisperer was taken, so it's just Whisper, just as it's written on the page.
Got it. Okay. Shucks, man. Someone hung on that domain. It's probably Jeff Daly, Dr. Campbell.
Well, then we're going to have to talk, Jeff.
Everything's for sale.
Well, yes, it is.
Well, Dr. Campbell, thank you so much for a great program.
Supplies, right?
I love this banter. It's like we're at the bar together. We all miss this kind of interaction. I like it. I'm stuck in my office. Everyone wants to get out a little bit. Big thank you to Dr. Campbell, Jeff Daly from Darby Dental. Thank you for making this happen. And stay safe, everyone. Take care.
Appreciate
it.
Thank you,
everybody.
Thanks so much.
Thanks, Dr. Campbell.
Bye-bye.